Welcome to We Are Valley, a podcast by Valley Medical Center, located in Renton, Washington. We Are Valley is dedicated to providing you bite-sized advice to improve your health and well-being, and keep you updated on the latest medical guidance. This podcast is for informational purposes only and is not intended to be taken as medical advice. So please talk to your provider before making changes that will affect your health.
Hi, everyone. This is Alex McGuire. I'm one of your producers of the We Are Valley podcast and your host for today's episode. I'm sitting here today with Dr. Eric and Dr. Olga, and we're going to talk about minimally invasive gynecologic surgery. Both of them practice with Valley Women's Healthcare, and I'm going to hand it over to them to introduce themselves.
Great. Thank you, Alex. I'm Olga Valieva. I'm one of the GYN surgeons here at Valley Medical Center. I've been here for over 8 years and love performing minimally invasive gynecologic surgery.
And I'm Eric Schmidt. I am also an OBGYN specializing in minimally invasive gynecologic surgery with Dr. Valieva. Here just 1 or 2 years shy of her as we did our residency together. Mm-hmm. And she was my senior resident, which I hate to admit, but she was.
Yeah, I bossed him around. It was really fun.
Awesome. Wonderful. Well, thank you both so much for being here. Let's just kind of start it from the baseline. When we say minimally invasive gynecologic surgery, what are we talking about?
Good question. So minimally invasive gynecologic surgery means doing typical or traditional gynecologic surgery in ways that minimizes tissue trauma and expedites recovery for the patients. We try to use, as often as we can, advanced approaches such as robotics or advanced hysteroscopic approaches to make sure that patients have a quicker return back to their normal lifestyle.
And so a big part of that would be if somebody is, has heard they had a hysterectomy and someone had a larger cut incision. We do these cases with smaller cut incisions so patients can go home same day, quick recovery, back to work, back to their families sooner is kind of the example for that.
Gotcha. So when we say minimally invasive, it sounds like the outcomes tend to be shorter recovery times, less healing because the scars are smaller, the openings are smaller.
Yeah. And also oftentimes people report less pain with those as well because it is smaller incisions and just less manipulation of their tissues overall.
That's a really great clarification. Thank you for that.
I was going to say, on top of that, also additional expertise in certain conditions that the general practitioner may not have as much experience with, like endometriosis and fibroids.
That leads me really well into our next question, which is, what are some common examples of conditions that can be treated using MIGS?
Common conditions that we treat would be things like fibroids, people who have abnormal heavy bleeding, endometriosis, but it can incorporate a number of different things like ovarian cysts or we do a number of different other procedures too.
Yeah. One more thing to add is while Eric and I don't particularly do this, but urogynecologic problems like pelvic organ prolapse is something that MIGS providers can do as well. It's not what the two of us, we practice, but we do have other specialists that do here at Valley.
We kind of talked about the benefits of MIGS as a treatment. Why might somebody seek out a minimally invasive gynecologic surgery, or why might your provider suggest it as an option?
Patients should look for minimally invasive gynecologic surgery as a way to treat more complicated procedures. Oftentimes I hear patients are recommended a larger abdominal incision just because, say, their fibroids are too big or they've had multiple other surgeries for the same condition like endometriosis. And they just don't want to go through another difficult recovery and a bigger surgery. And sometimes, providers might want to refer to them just because it is a more complicated case and they want to have more specialized treatment for these conditions.
And I think to add on to Dr. Olga's point, the specialty is rapidly evolving. And you hear stories from patients all the time about their grandma who had a hysterectomy, who, she was 30 and she had her ovaries removed. She had a large cut incision. She spent a week in the hospital. And now we are treating these with better knowledge, better surgical technique, and it's really benefiting the patients, trying to drive women's healthcare forward.
I think that's a really good perspective to take in terms of the advancement of technique is serving the patient, right? We are trying to find new techniques and new ways to improve patient outcomes. And that means that lots of times it might not look the same, but there are reasons that it doesn't look the same and reasons that we moved away from other techniques. Thank you for those answers. This is a little similar to one that I have already asked. What kinds of procedures or treatments may have a MIGS option? So if we're looking at like what types of surgical treatments?
Yeah. So the biggest advancement, I think, in our field for minimally invasive gynecology would be in fibroid treatment, for endometriosis treatment, where, we take out fibroids the size of a volleyball through an incision that's 2 centimeters in size. And often that patient might go home the same day. In endometriosis, we're focusing on excisional treatment of endometriosis. The treatments of endometriosis has evolved quickly over the last decade, with more knowledge, more light brought to the topic by, not only patients, community, and doctors further specializing in MIGS is what's driving the treatment of things like pelvic pain, endometriosis forward quite a bit. And so with small cut incisions, we're able to, in a way, we treat endometriosis kind of like cancer. We try to remove it all. We don't want to just note it on our operative report and leave it, or just burn it. We want to remove it. And so that's one of the big things that's changing. And we can do that with, hopefully, again, patients going home the same day. But, ovarian cysts, I hear stories of, patients tell me, well, my doctor was 50% sure they could do my surgery through small cut incisions. But when you go to somebody that specializes in this, the chances of us not being able to do it with small cut incisions is probably less than 1%. We are prepared for everything. And so we practice, the best way to keep the patient safe and recover the quickest is I might have gone off track there, but
no, that's all good stuff. Anything you want to add to that, Olga?
Yeah, I'd love to. One of the things too that often patients are coming to us is for fertility sparing procedures. I mean, a lot of these patients are younger, wanting to have a pregnancy in the future. And just like Dr. Eric said, sometimes providers are, they'll go to their doctors and they're like, well, we probably have to take your ovary, we have to remove your uterus because of the large fibroids or, adenomyosis, endometriosis, and you can't become pregnant. And that's really devastating for a lot of patients to hear. So we can approach these difficult situations in a way that helps them in the future and helps them achieve their family plans. And like Eric was saying, again, we're more specialized than the average GYN surgeon just because this is what we do. It's our bread and butter, if you will. So we do take on more complicated cases. We do let women have their organs for fertility or not if they don't want to,
Sure.
So it's a very different approach.
Awesome. Thank you for those answers. That's really insightful to hear about what this allows options for, right? Maybe with other surgical approaches, we don't have as many, but when we have a more nuanced and I don't want to say delicate because I feel like that's the wrong word, but when you have a more complex approach to a complex issue, right, it opens the doors to possibilities that maybe you wouldn't have been as successsuccessful otherwise.
I will say that it is a more delicate option.
Okay. Yeah, we can definitely use the word if we feel like that's appropriate. I just didn't want to. I didn't want to assert anything without that being led by your language. So thank you for that clarification. Valley is the Center of Excellence in Robotic Surgery. Both of you are board certified OBGYNs, robotic surgeons of excellence, and ABOG certified MIGS surgeons. What does it mean to be a certified MIGS surgeon?
So there are two ways to get certified in MIGS. One of them is to go through a fellowship. So this is in addition to our 4 years of general OBGYN residency, you do another 2 to 3 year fellowship depending on the program where all you do is gynecologic surgery and advanced gynecologic surgery. This is a newer route, I would say probably becoming more and more formalized over the last few years. When Dr. Eric and I were going through residency, there were only a handful of these fellowship programs and there were not technically fully accredited. So we went through a different route where we started as general GYNs, and over the course of several years, essentially just subspecialized in surgery. And then we did sit for the additional boards to have the focus practice designation for minimally invasive surgery.
And having a lot of these certifications and titles is nice, but I think it's a way to a patient to approach this when they see this like on a doctor's credentials is like that person's taken extra time and effort to care about that certain specialty or that certain niche of our very broad specialty as overall we're OBGYNs, but we've dropped the OB, not because we don't love it and love our patients, but we saw the need for advancing the care in gynecology, especially the surgical side. And so these just kind of show that we want our patients to know, like, we really care about this side of specialty. Yeah. And just like we're going to a conference next week, which is one of like the big, and not endometriosis, but we talk about a lot of endometriosis. It's AGL, American Advanced Gynecologic laparoscopist. And so, just all those things just show that, we care about this. We want to further drive this specialty and field forward.
Yeah. Yeah. And, there's only so many hours in a day. And if it takes, focusing further on the thing that you're passionate about seeing growing as a field, right? Sometimes that means other things get a little less time. Are there any risks associated with minimally invasive gynecologic surgery that you think patients should be aware of? And I will throw that to Dr. Olga.
The risks associated with minimally invasive gyn surgery are risks associated with any other surgery. Most commonly, there's risks of infection, but typically that's less than 1%. Obviously, if there's already an ongoing infection, that's a different situation. So injury to internal organs is incredibly rare, closer to like 1 in 1,000. Bleeding is the same. I would say the risks are all lower with minimally invasive approaches, just because, again, we're not making larger incisions. We're not exposing tissue to as much trauma, to as much bacteria. And the procedures typically are done quicker. So compared to traditional, I don't want to say older, but traditional methods of gynecologic surgery, we do have lower risks and complications.
And to add to that point too, if you have a doctor or a surgeon that does one thing more often and really specializes in one thing, the chances are that they will have a lower complication rate per se. Someone that does more surgical volume generally will have lower complication rates.
That's really good to know. And I think a really good thing for patients to keep in mind as they're maybe considering MIGS as an option. Can you walk us through what a typical treatment might look like? What happens during a MIGS treatment? And then what does recovery look like? And we'll start with Eric.
So we've been talking a lot about the procedure of minimally invasive surgery, but it actually starts before the procedure in prepping a patient with expectations. And I know Dr. Olga and I both use what's called the ERAS pathway, which is enhanced recovery after surgery, which incorporates a number of different tenets to, again, same goal of make somebody's surgical experience better, less pain, less recovery, back to their daily life sooner. This would include things like we often do like preoperative medications to help with pain response afterwards. We use a lot of like local anesthesia during the surgery to help with pain response. And then after surgery, we often are getting patients moving quickly, getting them to sleep at home in their own beds, instructing, we don't want you just laying in bed over the next few days. We want you getting up, walking, eating a normal diet. I've heard stories of people needing like bowel preps for just a routine hysterectomy. And have a number of different issues. But the goal is what I say to patients all the time is, I want to interrupt your day, your week, your month as little as possible and get you back to living your normal life. So you don't have to worry about the issue that has likely been troubling them for quite a while before they see us. Because unfortunately we hear that all too often, where someone's been suffering with bleeding, pain, whatever it is, for so long until they finally see us. So that's the kind of what we do a little extra too. Now I think I forgot the original question.
What does the day of surgery look like, and like what might recovery look like after that?
Yeah, and Olga Tell us
Yeah,
what the reaction.
So I do this all the time during our pre-op visits just to kind of walk patients through the day. So patients will show up to Valley Medical where our lovely pre-op team will take them into their room, go over a lot of healthcare related questions and just general safety things. We have stolen a little bit of the airline safety checklist. Kind of, we do the same thing here just to make sure we're all on the same page about everything. If we need to mark a side, say we're doing a cyst removal, we want to make sure we mark the appropriate side. Is it the right or the left? I mean, we'll deal with everything we can. We have a patient meet with our lovely anesthesiology team just to go over their anesthesia and what that's going to look like and what that'll feel like. We see each other again as far as any last minute questions, concerns, and oftentimes patients don't have their partners or their friends, whoever's going to be driving them home with them at their pre-op visit. So we kind of go over again expectations, medications, what to do, what not to do. And, with anesthesia, sometimes things get forgotten as well. So it's important to kind of reiterate that information just one last time. And then we take our patient to the operating room where all the magic will happen. Typically, once the surgery is complete, they go back to their primary recovery, the PACU area, where the anesthesia wears off. And then once they're able to have a bit of a conversation with us, able to drink some water, maybe have a cracker or two, we bring them back to a private suite, and they finish their recovery. And most patients are able to go home within an hour or two after the surgery, just once the anesthesia wears off, once they're able to eat, drink, roam around the hallways, maybe use the restroom, whether they're groggy or not, the anesthesia will wear off. We have a pretty robust safety checklist before discharge, but most people are home within a couple of hours of their surgery.
That's super exciting. And then what might recovery look like typically post leaving the hospital? Like, are we looking at a couple of weeks, couple months? What does the recovery timeline look like?
Yeah, good question. So it kind of depends on the procedure. Some of the procedures, like the hysteroscopies, we really don't have a long recovery or much downtime. I mean, people are on their feet back to their regular business same day, if not the next day. For laparoscopic procedures, again, depending on the procedure, it may be a week or so. It could be 2 to 3 weeks. It could be 4 weeks. The bigger the surgery, unfortunately, the longer the recovery is just because of the nature of the surgery. But most patients are able to get back to work within a week or two of their procedure, and sometimes 3 to 4 weeks, depending on how physical their job is as well. So it depends both on the surgery and what their job and normal lifestyle looks like.
Right. Yep.
And there's more and more data coming out that, moving around, like often patients are told, like don't lift a thing. Well, that's not even that true anymore. Maybe, these lifting everything's just being reevaluated in the field and rethought to try and make a better recovery in everything.
We're not too precious about the process to not constructively think of ways to do it better.
Yeah. And everybody is different. Everybody heals at a different rate. We have people that are back to work in a week, and we have people that are back to work in 6 weeks. We all feel our pain. We all feel our recovery differently. And just like Eric said, like these restrictions of, bed rest for 6 weeks or no lifting for 6 weeks. I mean, they're there and potentially kind of carry over from the older methods, but not a lot of them are evidence-based. And so I'll often say, rule of thumb, if it doesn't hurt, go for it. Your body will tell you what you can and cannot do after the procedure.
So listen to your body.
Yeah.
Thank you. Those are both super helpful answers in terms of, I think, helping folks figure out if MIGS might be an option that they want. If somebody is interested in a MIGS procedure, what are the first steps that somebody can take if they think that might be the right treatment path for them?
I think that another way to phrase it is MIGS is kind of the new standard, with a few exceptions maybe, but minimally invasive gynecologic surgery, should be the standard of care for a lot of women. And I understand there can be areas where there is difficult to access somebody that might do it the way that we might do things. But it should hopefully be the standard of the surgery. And so if somebody is maybe getting a consultation for things like fibroids or endometriosis or ovarian cysts, and they're told that they might need a laparotomy or a large cut surgery or staying the night in the hospital, it's within their right to get a second opinion. And so how does someone find the right person? How does someone find someone that truly cares about the MIGS protocol and procedures and surgery. One, the profiles, and people will say, they, enjoy doing minimally invasive gynecologic surgery. We have robotic surgeon of excellence. We have the MIGS designation. And so that's kind of how to find somebody that would do it and get a second opinion. But yeah, I think everyone in a way should want minimally invasive gynecologic surgery for the reasons we kind of talked about.
Yeah. Anything you'd like to add to that, Olga?
Yeah. Often people, again, maybe they don't like the answer, don't feel comfortable with what they were being told. So I always encourage people, even after they meet with me, if they wanted to seek a second opinion, by all means. I want to make sure that you're comfortable. And patients will, in this day and age, gosh, I sound old, we have technology is available widely, right? So a lot of our patients will come from a different organization or a different hospital. And luckily, we're able to connect to a lot of these different organizations via MyChart and Care Everywhere. So we can often see their previous visits and records. Some of the smaller clinics or private hospitals may not have that option. So, or if they're out of state, we might not be able to see that. So if patients do bring their records with them, it's really helpful to go over them. And just to kind of go over their previous history and what treatment options they've tried, and then give them as many options as possible so that we can find the right solution for their problem.
Awesome. Thank you for those answers. Dr. Olga, sometimes if you're looking up minimally invasive gynecologic surgery, you might see a term vNOTES. Can you talk a little bit about what that means?
I'd love to. So vNOTES is, I know this isn't a real word, but the most minimally invasivest option that we have. So it is surgery done via the natural vaginal orifice. So we don't make any abdominal incisions. We only make an incision in the vaginal canal. And we are actually able to introduce our or endoscopic instruments through the vaginal incision so that we can do the surgery that way. Traditionally, we're able to do vaginal hysterectomies, without any endoscopic utility or instruments. But what we can actually do now is a lot more advanced surgical procedures. Say there's endometriosis or bigger uterine fibroids or even cyst removals through that approach. That way patients have a lot less pain. They don't have any abdominal incisions. And, I don't want to say that vanity is important, but honestly, it can be, especially for, people who don't want to have any large visible scars or multiple scars. It's a fantastic approach. Patients will also often report less need for pain medications just because they have less holes, if you will. But it has allowed us a lot more advanced approach to more complicated cases and even avoiding abdominal laparoscopic incisions just to go through the natural orifice and natural opening that we have.
Well, wonderful. And then we're kind of at the end of my questions. So I just want to open up the floor. Is there anything that we haven't talked about that you folks think would be good to touch on?
I think it's important for patients to know it never hurts to get a consult for what is ailing them. And the old thought of grandma didn't talk about it, mom didn't talk about it, or they, I hear patients say suffered through it. Come see us. We want to help with these things. We have, like Dr. Valieva said before, fertility sparing options. If somebody has fibroids and they're being recommended a hysterectomy and they want to keep their uterus, we have plenty of options for that. And so it's not always just things like hysterectomy. And then all the different options that cause pain, endometriosis, painful periods, it should be checked out. It shouldn't always be assumed normal. We want to see those things.
And one more thing I'll add, often patients will say well, my doctor said that it had to be a large incision. I have a lot of feelings about that, but if that's what you hear, seek another opinion. There are ways to get even the most difficult cases, the largest uteruses, largest fibroids, there's a way to get it done laparoscopically. And if there isn't, we'll talk about ways that we can make it happen. Seek a second opinion.
I think that's really important for folks to keep in mind.
Well, if you or a loved one are interested in learning more about minimally invasive gynecologic surgery, you can learn more on our website, which we will link in our show notes. Our guests today have been Dr. Eric Schmidt and Dr. Olga Valieva, who are both gynecologic surgeons with Valley Women's Healthcare. They're both board certified, robotic surgeons of excellence, and have focused practice designations in minimally invasive gynecologic surgery from the American Board of Gynecology. Again, I just want to thank you both so much for your time today.
Thank you.
This has been We Are Valley, a podcast produced by Valley Medical Center in Renton, Washington, as a part of our mission to care for our community like family. If you liked this episode, be sure to subscribe to our feed for more great health content. And for more health resources or to find a provider, visit valleymed.org. Thank you for joining us.